Methotrexate toxicity usually is leukoencephalopathy. So you can see over time, the more methotrexate you give, the more white matter changes there are. On the other hand, there are patients that have 8, 16, whatever doses, and nothing happens. But I think that's one of the toxicities. And for recurrent, like, how do you distinguish between recurrent disease or, CNS involvement versus methotrexate toxicity? In general, disease is enhancing, and these treatment-related changes are non-enhancing. But we have all seen patients with primary CNS lymphoma that have flare or T2 flare changes without enhancements. So I think that also the dynamics of it is something to keep in mind if the patient deteriorates, and it's really harder to quantify T2 flare changes than an enhancing lesion or a nodule that gets bigger over time. I always, consider spinal fluid collections or even, a biopsy. But the things that methotrexate does more acutely, like stroke-like symptoms and things like that, more short, like immediate side effects of the treatment and not long-term results. But that's usually, in general, there's not a lot of ambiguity what it is, to be honest.
And it doesn't happen often, but I think that highlights what you said at the beginning, that ideally, if questions like this come up, if those patients are managed by somebody who has a lot of experience managing those lymphomas, it's kind of easier to interpret, because sometimes those lesions could be not necessarily progression of the disease, but some of the lesions, some of the changes which we induce. So you really have to be very careful in interpretation, and again, highlights what you said about the importance of involving really tertiary centers, so centers who have experience in treating those patients. In your practice, if you have a patient with aggressive lymphoma, who do you typically prophylax, if anybody?
So what I do is I look at the CNS IPI scoring system for these patients. I check in patients with a high CNS IPI score, in the sense that I do an LP with CSF analysis, and during the first LP, we give them a dose of methotrexate. But beyond that, if the initial LP is negative, just with the data emerging that it is controversial and we're not seeing much benefit, what I've been doing is definitely doing prophylaxis for patients who have renal involvement and adrenal involvement, for sure, testicular involvement. And I would say with double hit lymphoma, it's sort of become controversial. I check, but I don't necessarily do CNS prophylaxis. If they have epidural disease or disease that I feel like is close to the spine, then we've been sort of giving them CNS prophylaxis too.
Yeah, this is a struggle to really identify those patients at risk, because CNS IPI is, even at the higher risk, the risk is not necessarily as high to justify prophylaxis in everybody. And then we know that even on the high CNS IPI score, there's still quite a diverse group of people with extranodal involvement versus not, people with ABC subtype or different molecular subtypes, which we may feel would be more likely to relapse in CNS than others. So a lot of work needs to be done, I think, in the biomarker space. Christian or Katie, any biomarkers you use to kind of identify patients for prophylaxis? If somebody had a MY88 at the diagnosis with ABC subtype, would you be more likely to say yes, prophylaxis patients with high-dose methotrexate, or?
That is a good question. If it's in the cerebrospinal fluid, yes, I would. I would actually not prophylactically treat them. I would just treat them.
Yeah.
I would just take that as if you would find an abnormal, lymphoma cell in the spinal fluid. That is actually interesting. We have a similar. I know it tracks off a little bit, but we have a similar experience with ocular lymphoma. What do you do when you find these mutations in the cerebrospinal fluid? Do you act on it or not? Do you give systemic treatment, local treatment? I think that is a similar discussion than what to do with CNS prophylaxis. But yeah, no, it's more about the anatomy. Where is the lesion? What organ is affected that you give prophylactic, or even, methotrexate plus chemo.
Yeah. In the cooperative groups, we had this discussion, can we develop some prophylactic study in aggressive lymphoma? And try to define the benefit of it because the data is so mixed
Hmm.
in this space. And unfortunately, because we don't have those good predictors, the number to do such a studies of patients would have to be very, very high. And with all the other therapeutic interventions in this space, this will be very hard to do. So unless we have some better liquid biopsies or MRD assessment, maybe assessment from the fluid, I think this question will probably remain unanswered for a while.
Yeah.
And unless we have those biomarkers.
There's one imaging issue that always comes up, and that is in the upfront. So you have a tumor that shrinks to 90%, 95%, and there's still some enhancement left. And then there's always like, is this refractory disease or what is that? In most cases, if you have a very quick, very profound response, and that enhancement is in an area where you had a very expansile lesion or a biopsy, then usually it's not tumor. They're usually also too small to do a FDG PET to show that there's activity or not. But that is a big issue that we're facing in the field is, how much enhancement is physiologic because of the disease and the location and the interventions, and what is disease. So that is something that comes up a lot in discussions. But I think, again, it's the dynamics. If you have a big tumor shrinking to nothing, and then a month later you still have a little bit of enhancement left, that is usually not disease.
And I think to add on to that imaging, I think for long term, particularly if a patient has received radiation and has maybe had stereotactic boosts, they can develop enhancing lesions that are in fact radiation necrosis.
Yeah.
And I've even had patients that have had active disease in one area and radiation necrosis in another area. So you may have to treat radiation necrosis in rare circumstances in your primary CNS lymphoma patients. That's something that can come up and has been seen and can be treated appropriately. And then the other imaging is you can, not just in the contrast enhancing, but also in T2 flare imaging and also in certain diffusion weighted imaging, you can get a smoldering pattern of lymphoma that I think can be seen. It may look very indolent, but ultimately it will blossom into a recurrent lymphoma. So need to pay attention to those smoldering lesions. Again, extremely rare pattern. This is where I think you need to utilize a specialty panel or specialists or a tumor board for those unique cases.
Avi,
This kind of highlights the importance of having like a good neuroradiologist, which we're fortunate to have, and also the importance of tumor boards. I feel like in almost like every other CNS tumor board, we have these cases being presented, and it's a similar discussion of what we think is active disease versus what we think are treatment-related changes.
Yeah, again, you're showing the strength of this multidisciplinary approach. We know that indolent lymphomas, like marginal zone lymphoma, occasionally can involve CNS. Also, CNS complications and involvement can be seen in the setting of, let's say, Waldenström macroglobulinemia. So in the setting of other indolent lymphomas and marginal zone lymphoma, do you approach those patients any differently? Maybe I'll pass it to Avi.
I would say depending on the presentation, if it's an aggressive presentation, patient is pretty sick and you're seeing a lot of disease, then I usually go with the methotrexate-based approach, just because we're trying to debulk the tumor and get him back to a decent performance status fairly quickly. So I'd say in terms of the approach, it's usually like a high-dose methotrexate-based approach, or BTK inhibitors is something that we usually do.
Christian or Kathy, any other approaches?
Well, we have for some of those very indolent lymphomas, particularly if they involve just the dura, you can give very low doses of radiation and get very good control for those patients. And I have a series of those patients that I share with my radiation oncology colleagues that have done quite well and can continue to be very, maybe they are initially, just as Avi said, they could be very sick at the very beginning, but can quickly get better. So don't forget about those rare indolent lymphomas that you can just give a really low dose of radiation to.
Yeah, and I echo that too. You can actually have a very extended dual involvement and contour the radiation field. Not that I'm a radiation oncologist, but do that very nicely without ever affecting the brain. And so they're very, very sensitive, and that might be it. The other thing that I also where I get consulted is a parenchymal involvement or just dual involvement, and can we just do systemic treatment? Or do we need to add methotrexate? That's always a big question. Or is it leptomeningeal disease or not? Is it neurolymphomatosis with leptomeningeal involvement or not? I think that's where we all also get our input. But I think that it really is a smaller patient population, and I think there are multiple options, and it really depends on the patient's presentation, the dynamics, and what kind of subtype it is.
Yeah, those so very valid points. Always, or at least with my fellows, we're always discussing where is the blood supply coming from. Is it coming from systemic circulation, which is systemic type? It could be helpful, or is it truly intra CNS disease, which would require high-dose methotrexate and all the approaches of the drugs which penetrate to CNS, which we discuss. So, Christian, patients with Waldenström macroglobulinemia can have a number of CNS presentations, including hyperviscosity and other things, but also being Neal syndrome. Can you tell us a little bit how those patients present and how do you manage those?
Well, I rarely see them actually. They're not that common, isn't it? Usually it's leptomeningeal involvement, what that I see. So you have some cells that obviously cause some neuropathies, double vision, swallowing difficulties, sensory changes, sometimes gait instability. My experience is that they actually do very well with methotrexate, obviously. Intrathecal methotrexate would work, or a combination of a BTK, rituximab, we have done that, or methotrexate, intrathecal methotrexate, and BTK inhibitors. So it all really depends on, again, the dynamics of the disease, the debilitating symptoms, and what kind of treatment they already received prior. But it is it's a BTK sensitive disease still.
Mm-hmm. Yeah, a lot of patients would respond to BTK inhibitors. In general, Waldenström macroglobulinemia is quite responsive to it. I tend to actually use sometimes bendamustine as well. It actually does have penetration to CNS.
Yeah.
So all good bendamustine tends to be producing some responses in combination with Rituxan in those patients as well. Kathy, any other approaches from you?
Actually, those are extremely rare patients, and usually those are shifted to our hemonc colleagues. So
management. Okay.